I'm an adult endocrinologist at the University of Washington, and today we're going to be talking about male health. My team who helped me with this was Andrea Rowe, Kelly Mason, Vin, and obviously Melissa are our mentors, so I'll go ahead and get started. Let's see if I do well with this. So before we get started, I'll talk about kind of where we're going to go with the talk. So I kind of split it up into two things. One is what we know about CF and male health, and one is what we don't know. So when you think about what we do know about cystic fibrosis and male health, I'll focus initially on fertility, a little bit of the why and the how of infertility in males with CF. Briefly touch on treatment options, but won't go too into that because I'm not a reproductive health specialist. Then we'll talk about the impact or lack thereof of modulator therapy, which is a theme during this conference. Then we will talk a little bit about hypogonadism, and then last but certainly not least, in what we know, we'll talk about experiences, attitudes, and education surrounding sexual reproductive health in males with cystic fibrosis. And then I'll end on what we don't know about CF and male health and kind of future directions and questions. So male infertility, and I think unlike female infertility, where Andrea just mentioned that we kind of not quite sure where that comes from, with male infertility we're pretty sure in cystic fibrosis that it comes from the congenital absence of bilateral vas deferens, or CBAVD. So you're missing this, and that is why 97 to 98% of men with cystic fibrosis are infertile. If males with cystic fibrosis do happen to be fertile, then they likely have a very mild CFTR mutation. And because the absence of the bilateral vas deferens means that there is no sperm canal, which means that the sperm can never make it to the semen, and then you have thinner ejaculate, and this is actually supposed to be lower semen volume, but I suppose it's also lower semen value. So sperm production in the testicles is normal in 90% of males with CF. So that's 90% of males with CF, but what about spermatogenesis? Maybe there is something that we're not sure is actually abnormal. So there's not that much out there on this. This is a group in China. This study was published in 2019, and this is kind of the only group that's doing a significant amount of research into this and how CFTR mutations may be affecting spermatogenesis. And this study built on a prior study where this group looked at the impact of microRNAs and looked at microRNAs and how they're involved in spermatogenesis. This specific study, they used transgenic mice who had overexpression of this microRNA MIR15B. I won't get too into this, but they basically saw that having too much of that impaired spermatogenesis. So then they did in vitro studies looking at how the CFTR mutation affects the expression of the microRNA MIR15B, and the CFTR mutation impairs regulation of this microRNA. So the conclusion of the study was that the CFTR mutation, by impairing regulation of this microRNA, could then affect spermatogenesis. So keep in mind, not very much research into this at all, and this is what we do have. Oh, wrong place, there we go. So if you're evaluating your patients, to start the evaluation for male infertility, is similar in patients with cystic fibrosis as it is for the general male population, where you would start with lab testing, gonadotropins, testosterone levels, transrectal ultrasound, and semen analysis. And then once your fertility experts have gone through this, then you would talk about what their options are for treatment. And pointing at the right spot? There we go. So treatment options, before your fertility specialist would even consider talking about what your patients could do to achieve fertility, it's recommended that you tell them about genetic counseling and specifically offer them CFTR mutation screening for their partner, because this is very important. And then if your patients were to decide to proceed with fertility treatments, then the main thing right now is sperm extraction from either the testicle or the epididymis, and then you have intracytoplasmic injection, ICSI, into an oocyte. And this process that you can sort of see in this graphic is it just requires one sperm. And this process can actually result in over 60% pregnancy rates with just one or more rounds, and can range in pretty successful amount of live births with this treatment. what about the impact of highly effective modulator therapy? So this is one area where, unlike in many of our other talks where we have a lot of hope, this is not an area where there is hope that highly effective modulator therapy will make a significant impact, because the defect of the congenital bilateral absence of the vas deferens happens in utero. As far as what studies have been done in this, there was a ferret model that looked at giving ivacaftor to women early in pregnancy. And there was potentially some preservation of the vas deferens, but that was one animal model study and was not that promising. So we actually don't think that highly effective modulator therapy will make a difference in male infertility. So shifting gears a little bit now to talk about hypogonadism in males with cystic fibrosis. And hypogonadism is low testosterone levels. So what causes the low testosterone levels in your males with cystic fibrosis? It's thought to be multifactorial. Chronic inflammation, these patients have recurrent infections, they also have regular glucocorticoid use, but we're not entirely sure. What about the exact prevalence? That's also kind of a theme with this. We're not exactly sure. So those numbers that you'll find in the data that we have right now is anywhere from a prevalence of 25 to 45%. And these studies were done on very small numbers. The most recent being a 2003 study done by a German group. Eckhard Lefke's group did it, and they looked at 40 men with cystic fibrosis who are median age of about 25, and they found that half of those men, so 20 out of the 40, had testosterone levels that were 2 standard deviations below normal. But again, that data's from 2003, and it's old, and it was very small. So we don't really know the answer to this, so future research options should definitely look into this. One of the tricky parts is, Lefke's study, they looked at it, it was men who were not in acute illness, were not on steroids, so it's kind of critical sort of catching patients in that window to get a good idea of prevalence. Why does this matter? Because of health impacts, obviously, and so decreased bone mineral density, low muscle mass, poor energy levels, infertility, and impaired mood are just some of the issues that your patients could be experiencing if they have low testosterone levels. Our center actually recently decided to stop just checking these kind of at random, so now it's kind of more based on symptomatic screening at our center. And so if you screened your patients, how would you screen them and diagnose them to see if they have low testosterone levels? And it requires the diagnosis, this chart is going to be very difficult to read, the diagnosis requires 2 separate morning total testosterone levels that are below range, and then this chart, which is very hard to read, is actually pulled from the Endocrine Society guidelines by Sanjay Basin et al. About treatment of testosterone, and it just shows you the list of what you would do if your patients ended up having low testosterone, and it ranges from the top here, starts with what your IM injections, going all the way down to at the bottom is nasal testosterone gel. I have never used nasal testosterone gel. The ones at the top are the more common. So that's your IM subcutaneous injections, either weekly or biweekly. Then you have your testosterone gels, you have your axillary topical solutions. This also mentions testosterone buccal tablets and testosterone pellets, but I'm not, and testosterone patches, but none of these are, I have used clinically, and maybe in the discussion we could talk about if anybody is using these. So, to shift gears again, to talk about what I think is one of the most important aspects of the male health with our patients is the experiences, attitudes, and sexual reproductive health education for these patients. And this study that I'm showing here, this is by a researcher out of Australia, Susan Sawyer. She's done a lot of work into this and has done a lot of qualitative studies and surveys talking to both providers and patients about their sexual reproductive health attitudes, preferences, practices. And so this study here was done in Australasia, 5 different CF centers, and they had about 264 patients complete the surveys. And what I thought was most striking was that 68% of men want more sexual and reproductive health information. And I pulled this quote directly from one of the surveys, which was that these patients want more information, but they don't actually know how to ask, or even in some situations, who to ask. So another thing that this study pulled out was that less than half of these patients are actually getting the information from their preferred source. And when you look at the data as to asking these patients what their preferred sources are, it was kind of split in thirds, which makes it a little tricky, but 1/3 wanted to hear it from their CF team, who they viewed as their primary care providers. The other third would have preferred to hear it from their parents or their family. And then there was another third of the patients who wanted to actually get it from a mix of resources, educational pamphlets, online information classes, that kind of thing. But basically, the more than 50% of these patients are getting it from a source that they wouldn't want, and over half of these patients don't actually know who to ask. So this next chart here is what I put up. I think this is really important to realize that as providers and we're talking to these patients, what are kind of the key facts that we should bring up with them? And I pulled this chart from a great review paper by Lyon and Bilton, which basically said your patients should know, your males with CF should know that 95% of males with CF are infertile. Infertility doesn't mean that they're impotent. Sexual function is normal. And spermatogenesis is likely to be normal pending something coming out of these other studies. They should know that ejaculatory fluid doesn't have sperm, so it's of lower quality, lower volume. But despite this, that there are fertility treatments available for them, that they can, sperm aspiration and intracytoplasmic sperm injection can result in a very successful pregnancy. And they should also know that genetic counseling is available for them. Oh, wrong one. So, future directions and kind of where we can go from here. As you can see, I think there's a lot to be explored in this field because just really not very much has been done. The most recent stuff you'll find in literature on this is a white paper that me and other folks recently wrote as like getting heads together to prioritize areas of research for cystic fibrosis and male health. And then there was a paper written by John Yoon and his group in 2019 that was a review paper looking at this. So it's really sparse as to what's being researched and what's being looked into. What do I think is the most important thing is that we first need to start with improving sexual and reproductive health experiences for men with CF. This is, again, this is the Susan Sawyer's group did another survey, and what I think is really important here is that we need to talk to them early, because if you look at this, so when they're told younger ages, either less than 16 is the dark bar here or 16 to 20 is the light gray, that they have infertility, there's not really much of an effect. But if you wait until they're over 16, which is here in the white bars, then they can be really very upset at finding out so late in life that this is something that nobody ever talked to them about. So I think as providers, we need to focus on getting patients information earlier and from their preferred source. And we need to be more transparent about this and provide them the education and the resources and the space to ask their questions. As far as future research areas, as I mentioned, likely very little impact of highly effective modulator therapy on fertility. Could it have an impact on hypogonadism? Definitely, potentially, and that's an area for us to look into once we've looked into just prevalence of hypogonadism, I think, more. And then I didn't put this on this slide, but what about the effect of highly effective modulator therapy? If there is an issue with spermatogenesis, then perhaps that's also another potential area of research and questions and impact for the highly effective modulator therapy. So with that, that's actually all I have. So I'll take questions during Q&A. Thanks, guys.